Kidney stone. A kidney stone is a hard crystalline mineral that is formed within the kidney or the urinary tract. It is formed when the urine becomes concentrated. In order to understand this, we take an example. Now, in a cup, we take a solvent and we add solute to it. When you mix it, this solute becomes diluted and it gradually disappears. Similarly, when we add more solute to that same solution, there becomes a time when it is no longer able to dilute it. Rather than becoming a dilute solution, becomes a concentrated one. Now the left solute particles, what they do is they start to aggregate together and form a crystalline material. A similar example that takes place in the kidney. When you're taking something, obviously it will get filtered out from the kidney, but there will come a time when you are taking a lot of solute, these solute will become aggregated and the urine will become concentrated. These lots of solute will come together and they will form a crystalline material known as stones. Now, in the body, stones are formed by various materials such as calcium, oxalates, and uric acid. Now, alone intake does not mean that this would result in stone formation. Stone formation can also be due to lacking substances that prevents these crystals to aggregate. Now, how do you receive calcium in the body? By cheese, yogurt, sardines, canned salmon, beans, lentils, almond, and leafy greens, whereas oxalate is received by taking spinach, prawn flakes, rhubarb, beef, and even french fries. Now, this is a very absurd thing, but okay, as well as nuts. Now, uric acid is received by abnormal metabolism of purines, which can be seen in gout as well as leukemia. Now, there are various types of stones. Basically, the main classification is of four types: calcium oxalate stones, uric acid stones, struvite stones, as well as phosphate stones. Now, the calcium oxalate stones are sharp as well as they are irregular. Whenever they adhere or they are obstructing some pathway, what they do is they injure that area. So that would result in bleeding. Similarly, you would see blood in your urine, which is also known as hematuria. Now, these calcium oxalate stones are formed by hypercalcemia, which can be due to any abnormal metabolism of vitamin D or abnormal absorption, etc., as well as primary hyperparathyroidism. Now, your parathyroid glands are present behind your thyroid, they are 4 in number, primarily indicating the problem being in this gland. So, the problem most commonly are adenomas and carcinomas, which result in abnormal metabolism of calcium, resulting in increased amount of concentration of calcium in your body, which can result in calcium oxalate stones in the kidney. Now, the calcium oxalate stones are what they are. They are radiopaque, meaning you can see them on an X-ray. So, before knowing the abnormal pathology, we need to know the normal anatomy. Now, whenever we do an X-ray, we cannot see the renal calyces or the ureter or the bladder. What we do is we inject a dye into the body and wait for some time when the dye is able to receive by the kidneys, and these dye is then similarly excreted out. So, as you can see, we can due to this dye, we can see the calyces as well as the ureters as well as the bladder. This is an IVU. Now, whenever there is calcium oxalate stones are formed, this would obstruct any pathway. Now, here in this picture, we can see it is obstructing the renal calyces. These are various in number, due to which we are not able to see the ureter as well as the we are able to see the bladder because that kidney is functioning properly. Now, Struvite stones. These are found by aggregates of magnesium, ammonium, as well as phosphates. Now, these stones have a tendency to grow large, resulting in a stag horn-like stone. Stag horn name is self-explanatory, in which the stone appears like a stag horn. This has a tendency to block the collecting duct, which can also lead to hydronephrosis, which means accumulation of fluid in the kidney, which results in its abnormal dilation. Now, lastly, we have uric acid stones. These are multiple, but the main problem in this is they are radiolucent, meaning you cannot see them on an X-ray. So, in order to diagnose them, we do an IVU, which we have previously discussed, that we inject a dye, and similarly, we can see the defect defect that is being present if the dye does not go down to the bladder. And we can also confirm it by a CT scan. This is normally seen in gout and leukemia. Gout is a normal metabolism of uric acids, and leukemia, what happens is there is an abnormal growth rate of the cells, due to which these cells after some time would break down and resulting in increased amount of uric acid that is formed in the body. Now lastly, we have phosphate stones. These are formed by infection produced by urease producing organisms such as protease and staphylococcus. Now these organisms secrete enzyme urease, which helps to break down urea into ammonia as well as carbon dioxide, which results in phosphate formation, phosphate stones formation. Now the symptoms of a kidney stones are there are severe back pain or pain in the lumbar region, and this pain can radiate to the lower abdomen and the groin. But the back pain is specific, or the lumbar pain is specific, that the stone is present in the kidney area. Now, whenever this pain radiates to the lower abdomen or to the groin area, this is indicating that now the stone has dislodged or is stuck in the ureter. Now, this type of pain, it is very fluctuant. It comes in waves, and there is pain upon urination. Pain upon urination again indicates that it is stuck in the ureter, and because it is rubbing against the mucosal lining, this will result in bleeding from that area, which will give the urine a characteristic red and brownish color. Because of the stasis of urine behind this area, this will become a prone area for bacterial infection to occur. So similarly, in some instances, the urine can also be cloudy and foul smelling, because now the kidney is not able to function properly and drain its waste products. The waste products would accumulate in the kidney as well as in the blood. So this will result in nausea as well as vomiting. Now, what are the signs we can understand that this is actually a kidney pain? There will be pain at the renal angle. Renal angle is found between the vertebral spine as well as between the 12th rib. This is also shown here in a man that is facing backwards. And there will also be hematuria, as I've already explained, that the blood in the urine. Pyuria, which is WBCs that are present in urine, which are indicating that there is infection there. And uremia, which tells us that there is increased concentration of urea and creatinine in the blood. Now, how would we investigate a kidney stone? We can do this by taking an X-ray, KUB indicating kidney, ureter and the bladder, ultrasound, IVU, intravenous urograph, DPTA scan, and non-contrast enhanced helical CT. Now, this is an X-ray. In an X-ray, whenever you are looking at an X-ray, first of all, you need to know what view it is. So this is a PK view, and then you need to appreciate normal anatomy, which is that you can see a 12th rib, the 11th rib, as well as the 10th rib. Now you can see the spine. This is the lumbar spine. You can see the hip bones. There is the sacrum. Then you see that this is an abnormal radiopaque shadow. Possibility of this area is occupied by the kidney, so this possibly must be kidney stones, which are numerous in number. Then we have an ultrasound. We can see the contours of the kidney. Now this is very good because it can tell you how many millimeters or centimeters of stone is present in the kidney. Now this is an IVU. IVU, as I've already told you, you inject a dye into the vein. Now you wait for 15 minutes and that dye is taken up by the kidneys. After 15 to 30 minutes, that dye goes into the ureter, and after 1 to 2 hours, it is received by the bladder. So approximately you need to do 3 X-rays after injecting the patient with this dye. Similarly, if there is no obstruction or no local defect, so you can identify that the kidneys are functioning normal. But if there is an obstruction, now the dye would not be draining here. So after this, what we do is, if there is an obstruction of this kidney, we'd like to know that if we relieve this obstruction here, would the kidney be functioning properly, or is the function being lost? So after performing an IVU, we do a DPTA scan, which determines the GFR. So even if there is an obstruction, there will be a normal GFR in both of these kidneys. If there is abnormal GFR, we assume, or we simply know that this is the point in which we need to remove that kidney because its function is lost. So this IVU and DPTA scan also helps us determine treatment of the patient. Now this is a non-contrast helical CT. In this you can see the kidney, both of the kidney present, and here you can see an opaque white clear shadow, meaning that a stone is basically present here. Now, treatment depends upon the size. So the first treatment is observation, the second medical expulsion, extracorporeal shockwave lithotripsy, percutaneous nephrolithotomy, retrograde intrarenal surgery, and open surgery. So if the stone size is between 5 millimeters or less, what we do is we only observe the patient, because this size of the stone it can spontaneously pass. If such a patient has pain, we give them analgesics. In order to prevent bacterial infection, we give them antibiotics, and we advise them to take lots of fluid in order to pass this stone. Then if the stone size is up to 6 millimeters to 8 millimeters, we do a medical expulsion therapy, which is by giving the patient tamsulosin. Now, tamsulosin is an alpha blocker. You need to remember your pharmacology again. We know alpha receptors are present on the bladder neck as well as in the prostate. So if you give an alpha blocker, there will be no constriction of these muscles. Instead, there will be relaxation of these smooth muscles. Similarly, the stone, if present anywhere around in this area or above, there will be smooth muscular relaxation, due to which the stone will be easily be able to pass through this tract. Along with this, we give the patient analgesics and plenty of fluid. Analgesics to provide pain relief, and fluid to basically provide enough urine in order to pass it. Now we give this drug approximately 0.4 mg and once every night. Now, if the stone size is approximately 1 to 2 centimeters, we give the patient extracorporeal shockwave lithotripsy, also known as SWOL. And this, the stone is basically first focused and then bombarded with shock waves that helps to break it down into fragments that are easily being able to pass through the urinary tract. Now, the indications for this is you can only do this if the kidney stone is less than 2 centimeters or the stone that is dislodged into the ureter is less than 1 centimeter. The contraindications are you should not give the patient if the patient has fever, they are very obese, uncontrolled hypertension, blood diathesis in which there is abnormal coagulation of blood, or UTI. Now, if the stone size is more than 2 centimeters, then we do is percutaneous nephrolithotomy. And this first we do is we puncture that respective area by a nephrostomy needle. We inject that needle up to the renal calyces under a fluoroscopic guidance, because we do not know where we are pointing the needle at. Then we add to the same pathway, we pass a guide wire. And then we remove the nephrostomy needle. Then along with that, we introduce dilators. Now, dilators helps to increase the size up to 1 centimeter. Then what we do is, lastly, we put an Amplace SS sheet through which we can pass a nephroscope. This nephroscope has the ability to visualize as well as fragment by ultrasonic waves, by pneumatic, or by laser. Now, whenever the stone is broken down, we remove these fragments by PCN tube or percutaneous nephrolithotomy tube. Now, the stone has been removed. Some of the stones can dislodge into this respective area. So what we do is we do JJ stunting. This stunt looks like a J, so it's known as JJ stunting. This helps to the remaining fragments to pass through this tract without causing a ureteric obstruction. Now, the outcome of this is 90% if the stone size is less than 2 centimeters and 80% if it is more than 2 centimeters. Now, lastly, we have a retrograde intrarenal surgery, And this what we do is retrograde, meaning you are doing something on opposite pathway. So we insert a ureteroscope, and by it goes through the urethra into the bladder, then the ureters, and it also helps to visualize stone, as well as by a red laser it can fragment stones, and these particles easily then are able to be excreted out through its normal pathway. Now lastly, we have open surgery. The indication for open surgery is this is done when your stone is very large and very complex, that is commonly done in staghorn stones, or it is occupying many calyces, again staghorn stone, or when there is failure of percutaneous nephrolithotomy and SVOL, or the patient is morbidly obese, because in a morbidly obese patient you will make a lot of punctures that will be creating a hazardous tract, and similarly you will also result in injury to the hilum as well as the blood vessels.